Hey everybody, welcome back to the Women's Health by Heather Hirsch / You Are Not Broken combo podcast episode.
Oh my
Welcome,
gosh, I
Heather,
love
Dr.
this
Heather
for
Hirsch.
us.
That just came to me, the combo. So this is what busy friends do. They have podcasts and then they never hang out because they're busy. So then we say, let's just talk and catch up and record one podcast episode and then put it on both our podcasts. And then we hang out and talk about all this shit in general. And here we are.
It's absolutely
for people
genius.
who don't
It's
know Dr.
absolutely
Heather
genius.
Hirsch, can you introduce yourself and then I'll introduce myself?
I would be more than happy to. Okay, I'm Dr. Heather Hirsch. I'm board certified in internal medicine. I completed a 2-year fellowship at Cleveland Clinic where I fell in love with all things midlife and menopause because it is the biggest gap in women's health care. And I've been doing that for the last decade. I have built 2 menopause clinics in academic centers, and then more recently went to have my own private telemedicine practice and growing that, as well as teaching, which is my number one thing, the love of my life, and just had such an incredible opportunity to spread all this information on various amazing outlets because women are really demanding more for their health. So it's a wonderful place to be. So that is me. And how about you, Dr. Casperson?
Yes. I am Dr. Kelly Casperson. I'm board certified in urology. And I got into hormones because of sex. That's my hook. Because I got into female sexual health like year 7 out of residency and like deep dove. And then everybody's like, well, you know what happens with menopause. But you know what happens with sex and menopause. And I'm like, what the hell? What the hell is going to happen with sex and menopause? Right? Like, I gotta figure that out. So then I was like, okay, what's the role of the hormones in sexuality? What's the role of the hormones in mood, which is libido's a mood? And turns out you have better sex if like your vasomotor symptoms are controlled, which is like an obvious no-brainer. And then I was like, why is everybody afraid? Blah, blah, blah. So I just started, I'm like, well, I'll talk about it a little bit more on the podcast. And then women are like, oh my God, talk about that more. So I sit in I always say I sit in the Venn diagram between sex and hormones. I'm sitting in the middle with testosterone.
Yeah, exactly.
So that's what I'm opening up I'm opening up the Casperson Clinic January 1st. That's what's big on my to-do for the rest of this year is getting the Casperson Clinic opened up, which is going to be sex med hormones. Basically the middle of the Venn diagram.
This is perfect. Do you remember when we podcasted back in 2020? Like together, I was living in Boston at the time and like sitting on my kitchen table. Like we've known each other for such a long time.
Jesus.
At least 4 years ago.
One of your podcasts I was listening to, you had on one of your best friends or your best friend who's a female urologist. And so I'm like, oh, well, okay. So she knows female urologists are super cool. She's probably friendly.
You guys have strong personalities, I will tell you that much.
That's like an understatement. We're abrasive in a very lovable way.
Exactly. I've been friends with Rachel for the longest time. Like I have actually a lot of female urology friends, but like also I'm like, I'll just be the cheerleader for you guys.
We need the internal medicine brain on all of this though. Like God bless internal medicine for being interested in menopause. Like it affects all the body systems, all of them.
Yeah.
Which is what internal medicine does.
Yeah. I say this all the time and like to no disservice to like any other specialty, but internists are trained in chronic disease management. And we don't have to call menopause a disease or a syndrome, or, you know what I mean? But it is, once you're menopausal, you're always postmenopausal, perimenopause, and the menopause transition, is years. And it is really intersecting the development of chronic diseases in women. So I think being an internist actually does really set up nicely the brain for someone to manage long-term hormone therapy. Not that many other specialties you and my OB colleagues can't, but that's what we spend the majority of our time training. We don't spend time doing surgery. So bless all of you for learning how to work under the lights and with the pressure, but we spend so much time thinking about the intersection of multiple medications and, biopsychosocial of health and health determinants and long-term health. I think we're really well suited to handle menopause.
I agree. Yesterday, I was like, I was like, I had a little bit of a headache yesterday, which is not usual for me. And so my brain's like, is this perimenopause? Is this perimenopause? And then I was like, wait, maybe you're just hungry.
Yeah. Maybe you should drink some water.
Yeah. I'm like, at this point, it's all perimenopause, but it's also possible that you haven't fed yourself very well today.
Yeah.
Things to think about.
My patients ask me all the time. They're like, Heather, is this perimenopause, or, is it depression? Is it COVID? Is it my parents aging? Is it, I'm like, it's all the things. But I'm so biased.
Is my marriage truly shitty, or do I need an estrogen patch?
It's both. It's all the things. Right. It's all the things. It's so hard being a female, though. I mean, as someone born with ovaries, imagine the hardest thing men have to do is go through puberty. That is the hardest thing they have to do.
The poor babies.
And watch watch basketball for 3 days while they sit on the couch with the ice pack on their groin.
Right. Fully supported by their partner, by the way, when they have a vasectomy, fully supported.
Exactly. And I mean, you compare that to just like 1 or 2 periods, okay, of a woman's life, and like so it's so crazy. And I always just think how wild it is that for all of time we've had these hormonal transitions and no one's paid any attention to how important they are. It's crazy. And as soon as you realize that as a urologist, you were like, wait, what? Wait, huh? Right? And then once you learn it, you can't unlearn it. Once you see it, you can't unsee it. You can't unsee it.
It's all GSM. Urology is all GSM. Yeah. Plus a little bit of not GSM. It's like GSM and some other things is what urology is.
I hope you guys are all enjoying this show, because we are really just living our best lives together. It's just been so much fun. Just like, if we podcasted together 4 years ago, it was like the middle of the pandemic or the beginning of the pandemic. Like, look how far we've come. Like, I mean, I think it's just wild. We could think of in terms of just how interested people are on the topic, how many celebrities are talking about it, how many events are taking place, how much money is being invested in this. I mean,
legislation.
It's wild.
Dude, entire countries are covering hormone therapy. Ireland's going to do it. BC just did it. The problem with British Columbia, though, which the British Columbia people will point out to me, they're like, we don't care if it's free. And by the way, it's not free. It's a shit ton of taxes. But we don't care if it's free. We don't have any doctors to actually prescribe it.
Who can prescribe it. Exactly. Or who know what they're doing. So this is my...
big changes countrywide.
Exactly. So speaking of that, I think that's an important thing. I'd love to say something too. There's kind of the blind leading the blind phenomenon right now, which is when people ask me anytime I'm somewhere, they're like, what do you see for the landscape for the next 5 years, 10 years? It's very positive, but for the next 5 years, you, if you're not a clinician, or even if you are a clinician, you are going to know more than your doctor for a couple of years. And there's going to be this very uncomfortable feeling of like you teaching them, or you telling them what to read, or you being like, this is so silly. And that's exactly the problem, is that we may have the insurance coverage for hormone therapy, but like, who is going to prescribe it, which is something I care about so much, right? That's why I wanted to create my teaching platform, so that physicians felt comfortable prescribing hormone therapy. And another key to that, which I think we can all vouch for, is experience, because there is more of an art to science, no matter what people want to say when it comes to prescribing hormone therapy. There is a lot of art to it. And so you also need to do it a lot, or experience it a lot, as much as you can. And that way, as there's nuances to every woman, which there is, you can help her. And so I've loved to be able to teach that, because I think, people will tell me all the time, I love learning your nuances through your teaching, because I don't have 10 years to see patients and learn those nuances. So I'll learn them through you. And, this is really the problem, is we don't have that's the bottleneck. The bottleneck is prescribers and clinicians.
Mm-hmm. Yeah, absolutely right. I was at the soccer field yesterday with 2 other moms talking about perimenopause, because that's what we do now. One of the women was like, I went to a doctor. This is a male doctor, and she's like, I'm in perimenopause. I would like some help. And he's like, no, there's no help. You're just gonna have to deal with it. And she basically read him the riot act, And which I was like, good on you for
Go
like,
for it.
sorry if the relationship broke, but like, good on you for being like, no, like I like people know that there's treatment available now. It's just that it hasn't trickled down to the doctors. And she's like, your wife isn't perimenopause yet, is she? Just wait. And I'm like, that's when the male, I'm stereotyping horrifically. I apologize to all those I offend. But it's like the men doctors start caring when it's in their house. That's when I really start seeing them step it up. And the female doctors start caring one of two ways. Number one, they're going through it. Or number two, women are coming in by the boatload. And they're like, I got to step this up because they're coming in now because of podcasts like this and because of social media and stuff like that. One thing I really like about your course in educating is there's a Facebook group for people in your course. And like, that's where like a lot of this art comes in. You know, somebody had just posted, I think it was today, somebody was like, oh my gosh, what a difference giving Divigel in the morning or in the night instead of the morning. Right. And it's just like simple stuff like that.
Simple things.
People are like, oh, and that's where like that supportive group, you just learn so much more hearing about what everybody else is doing.
I know. And I think like one of the things it's also doing is really building people's confidence, because there is still this ingrained idea, even if you're Heather Hirsch or Kelly Casperson, like we all grew up learning that hormone therapy is so dangerous. Now we've worked through a lot of those barriers and rewired our brains to not only logically see that hormone therapy is not dangerous, but you got to just do it. Right. And every time a patient pushes you a little bit, you're like, oh, but it's so nice for people to drop into that group. And sometimes, you know, people say like, just need some validation. We're like, do it. And I think that confidence is also really part of it. And that stems from just this messaging from above that estrogen is dangerous and harmful. And I love that, you know? And so you're going to be teaching a course too. I'm so excited about this.
Yes. I'm going to do a 3-part course with the Heather Hirsch Academy. And it's going to be sex med and testosterone.
Yes.
And super important. Again, you know, it's the same. This like the Venn diagram, right? Like I sit in the middle of the two things nobody got taught is like sex med and hormones, and that they have a darn big interplay between the two, right? Like the highest rate of distress in women with their sexual health is basically the perimenopause years. It's like 40 to 60 is the biggest rate of distress about their sexual health issues. And this is coming at a time right when men are starting to have erectile dysfunction kick in. You know, certainly it happens before age 40, but age 40, age 50, right? So now you've got in a heterosexual relationship, you've got both partners, both of them are like, what's happening? Right. And you either get on top of it and you address it or
no pun
you
intended.
Avoid it.
Right.
So but, we're going to do, it's going to start in November.
Watching you. Yeah. It's going to be amazing because you may have seen that the Professional Society came out with a little statement reminding people what hormone therapy is FDA approved for and isn't, and what testosterone is not okay for, which is like a lot of things apparently. And, you know, the problem is, my problem with these kind of statements is like, we will never have the research to show, or we will never have the money to say, approve hormone therapy for joint aches and pains, to randomize people to estrogen versus not, to get that many people in a double-blind randomized control trial to see if hormone therapy significantly reduces joint aches and pains is not only, I mean, not going to happen.
With a generic medicine?
Cost so much money.
Not going to happen.
Right. But it's also so silly that I think that we're, you know, again, it's like, well, we can't prescribe hormone therapy for joint aches and pains, even though those of us who do it see improvements all the time, but we can use SSRIs off label to treat menopause. That's okay. Like this is, and then what I'm trying to say is, again, we've got the same thing with testosterone, right? There's no data, or you can't use it for things like joint aches and pains, memory, bones. This is why your course is going to be so helpful, because people get emotional about these things. And I took that from Rachel Rubin. She was the one who kind of, you know, really put that idea in my mind that we get emotional about hormones. But when we look at the logic and we look at the research, like, I'm so excited for you to teach this class, because there's so much you have learned just from like podcasting and reading, and you're such an intellect. It's going to be amazing.
Yeah, totally. I mean, to me, I always like to have people like take a breath and take a frickin' step back. The FDA does not practice medicine. The FDA says we are not here to practice medicine. Keep in mind, insurance companies also say they don't practice medicine, right? And then the doctors, who are the only people who practice medicine, are following what they're saying? No. FDA approval is a very specific thing, but it does not dictate the practice of medicine. And I think we step back and we remember that. And then we say, okay, now what data do we have? And so I think that's one tail wagging the dog. The other tail wagging the dog is this circular argument of like, we know we don't have enough women's research, health research. We know women's health research is significantly underfunded. We can't use testosterone for anything because we don't have any research, right? And so I'm like, you can't say both. You're not allowed to say both. You can't say we don't have enough research and then don't use this because there's no research. Right? And so to me, I'm always like, take a step back, look at the crazy that this all is. And for like, I learned this in residency. I don't know, this might have been a famous doctor saying, I'm not sure. The hardest thing in caring for the patient is caring for the patient.
Right.
Exactly. It's like we get all caught up in like, well, I'm sorry you don't have low libido, because if you had low libido, you could have testosterone, honey. Like, no. No. Her sex life is one part of her whole life. And furthermore, libido's a mood, and mood's in the brain, and we have testosterone receptors in the brain. And Louise Newsom's paper that just got published in August shows 50% improvement in both cognition measures and mood measures.
And it's like we're not allowed to use the research is coming. Prospective studies. Right. You know, we have two important things. Clinical findings, which clinicians, you know, never seem to get enough credit because it's just not scientific enough. You know, you just see over 10 years. It's just not tidy enough. And that's not fair. And then prospective studies, which aren't deemed as valuable as randomized controlled trials. And that's not fair either, because that's what we have. And exactly, we talked about this last night in the providers group, which is like, well, you know, do you prescribe hormone therapy for joint aches and pains? Now, taking another step back, hormone therapy is FDA approved estrogen for 4 things: hot flashes, night sweats, GSM, osteopenia. You can always make the case that all women have GSM, right? Did you just not say 10 minutes ago, everything is GSM? And, you know, again, because of the pH changes, all women will have GSM. It's just whether you, exactly. Right. So there's usually an indication for hormone therapy to which then patients can see if they have improvements in other symptoms. And, you know, it's not as though anyone that, you know, of course, we're training on like a modern evidence-based approach to hormone therapy is doing anything outlandish. You know, I wish that the professional societies would go after people injecting pellets and spend less time worrying about who is prescribing hormone therapy for joint aches and pains. This is, you know, using FDA-approved doses. So I have a little bit of I didn't know that was going to come out, Kelly, but you just really pull it out of people, don't you? Like, I did nothing. I just asked you how you were.
Right? Yeah. I just asked you to introduce yourself, Heather.
right. And I'm Heather Hirsch, and I'm mad about all these things.
I mean, it's like, make it make sense, right? Like, have you ever had a joint ache and pain? It's not minimal. And here's the other argument: what else do we have? Show me what else we have that's safer. Right. Nothing.
Right. NSAIDs.
Right. And so it's like, you know, we've got NSAIDs. And NSAIDs have kidney disease, gastric ulcers. You know, it decreases the inflammatory response, which sometimes you need the inflammatory response. Like, NSAIDs aren't benign. Tylenol wouldn't be over the counter if it went through stuff today, right? That causes issues, liver issues. And so that's my argument, is like, what's better? And if there's nothing better, you're happy leaving these women untreated, right? And so it's a very narrow-minded discussion when they're like, stay in your lane with your hormones. And I'm like, do you want to talk about the side effects of SSRIs? I'm happy to talk about the side effects of SSRIs. 25% of women in this nation are on them. We should be talking about the side effects of SSRIs because Lord knows they're used off-label.
Right. There's the kettle calling the kettle black. Wait, what's the saying? The kettle's calling
and the kettle
calling each other
black.
the wrong colors.
Yeah.
Exactly.
But that, I mean, that's crazy. That SSRIs decrease libido, decrease sexual function, increase the risk of bone fracture. It's like literally the opposite of hormone therapy. So what would you rather take for your mood changes and your joint aches and pains?
I know. So we, herein lies kind of what I see is that there's still a lot of mixed messages, even among doctors doing FDA approved and evidence-based medicine and hormone therapy and testosterone replacement. There's still mixed messages. Like women are still not confused, but like just frustrated that we're not all reading the same textbook. And I feel their pain because they kind of come to me and say, I certainly still fall under your philosophy, but like, then why does one person say this and the other person say that? And the messaging, why aren't we thinking about the fact that if less than 4% of women are on hormone therapy or 5%, whatever, it doesn't matter. They're all small numbers. Why aren't we all working together to clean up this messaging? We're like nitpicking about, and it's funny that we're using this example of joint aches and pains because it's a perfect example. It could be dry skin. It could be mood symptoms. It could be, some of those things it's not proof for, but the joint aches and pains is so obvious. Like it's a good one to stick with as an example. Like, why can't we all just work to clean up the messaging? Because maybe we are creating the problem, right? Amongst the experts. And that's unfair because there's going to be a couple of years where patients know more than a lot of their doctors. But among the leading experts, there still seems to be minor disagreements that are being played out on social media. And we see this all the time. It's so sad.
I know. I'll take the counter just for funsies because that's what I like to do. Is like literally everybody said. I mean, this is a crazy analogy. I'm just using it. Literally everybody said like we cannot go to Mars. Going to Mars is impossible. Can't be done. Won't be done. And then this dude, love him or hate him, Elon Musk comes up and he's like, we're going to Mars. This is how we're going to do it. This is our timeline for doing it. Like we need people to push the envelope. In science, in medicine, it's how we progress. If we all agreed and we all stayed the same, nothing would ever get better. Right. And so to me, I'm like, listen, this discourse, if it makes people uncomfortable, I get it. But this is how nothing will move forward without a conversation, without saying why, without saying, why don't we use this off label, but we use these things off label, right? Like the conversation is the progress. And so for people to be like, y'all need to be on the same page. And I'm like, well, the world was flat until it wasn't, like,
I like that.
This is how, like, science is messy. Medicine is messy. This is messy. This is science and medicine. Right? Of like being comfortable with the uncomfortableness. And at the same time, like, Heather, I will be the first to admit if I know a shit ton about this. I've read more about this than 98% of people, like Heather Hirsch excluded, right? Like
maybe not.
I can't tell you the difference between cutting edge and snake oil sometimes. Right? Like it very quickly you get outside of like, I don't know, is microdosing GLP-1s gonna really be a thing? Like,
right.
I don't know.
I know, but like you hear it all from your patients.
Yeah. Right. Like, I have like 4 women come in last Thursday. They're all microdosing GLP-1s.
Right.
And so I'm like, I don't know.
I gotta read about this. Yeah.
Right. Yeah. But it's like how quickly the experts aren't even staying top of something that's kind of related, right? And it's like, and if I don't understand the difference between snake oil and cutting edge, which you can't always, like nobody else can.
No, right. Actually, that's a very, very good point. Is that the dialogue or the discourse is actually helping to change the narrative. Is part of the messaging is the messiness of the messaging, which is moving it forward, right? So that makes me feel a little bit better that maybe, it's the idea that a kumbaya moment could be helpful, but like maybe that's actually not what we need. Maybe we just keep on keeping on.
Yeah, like back when we weren't talking about menopause.
Yeah.
Right? Like
yesterday.
Right. Yeah. Yesterday. So like now we have a dialogue and it's messy, but I would argue it's better than not the last 20 years. Like the last, everybody agreed. Everybody agreed, except,
you
except
make
for
a
the
good
people
point.
who really knew. Everybody agreed hormones were dangerous and were killing you. Everybody agreed on that so much, we stopped training doctors on how to take care of hormones in menopause because we just all agreed.
It's
right?
crazy.
So it's like,
it's crazy.
let there be discourse, my friend. I'm here for it. Like, you know what I want to see at next year's Menopause Society meeting? I'm going to manifest it now. I want a pro and con debate estrogen for dementia prevention.
Oh, God. The only reason I laugh is like, oh my gosh, go for it. Who's on the scientific committee that you can talk to? Yeah. Well, so you may or may not know this, but the best part of the annual meetings used to be after the presentation, they would have free, not free. What am I trying to say? But you'd walk up to the mic and ask a question.
Open mic session.
Yeah, free mic, open mic, same thing, right? And it was the best. You could listen to the last 5 minutes of the talk where they do the summary slide, and then everyone would just like freeze because. Again, it is funny. The messiness has actually always been there. It's always been at these conferences. And then just with the, blowing up of all the different platforms and social media and younger doctors being on it, now we're just kind of seeing it every day and publicly. But it used to be sort of then. And then they, because they got a little too sloppy and messy and they maybe wanted to control the narrative, I don't know, turned it into more of like you submit an anonymous question and that's kind of how they answer them. But I want to ask you now, I want to talk about your book and the impact that it's had. Like, You Are Not Broken is such a great book because it also sort of breaks down the sort of how sex is also very biopsychosocial and not just hormones. I certainly also see a lot of women who, are really hoping testosterone is going to improve their libido, and that's just the magic bullet, right? So let's talk about that. Like, what is one of your favorite chapters in the book? I love the heteronormative discussion about, you ask any woman what's going to improve her libido, do the dishes. Like, let's talk about some of that stuff and what's, some of the proudest stuff in your book.
Yeah. I mean, to me, this book saves relationships. Like over and over, this is what I get about this book. It saved my marriage. It saved my relationship. Both me and my partner read it, and then we talked about it together. Like it's spurring conversation. People give it to as wedding gifts. Somebody gave it to everybody in their wedding party. They're like, this is what you need to know when you're going into a long-term sexual relationship. You need to know how to talk about it. You need to know how bodies work. And so I joke, like, this book saves marriages, and it's ended one of them. This book has ended at least one relationship. And that person was like, I realized that I was worthy of love and I was never going to get that. Right. So
sometimes that's a good thing.
Eventually happily ended a relationship. But that's what's this book, like, education is the key. And you do that with your courses, right? And I do that with sex. It's like, I'm not going to tell you how to have sex. I have no effing idea how you're supposed to have sex, right? That's not my job. But I can tell you why it's challenging and how your body works and what our nervous system needs to feel relaxed and calm and receptive, right? And then you go figure out how to have sex, right? But it's education. Probably my favorite, I guess, chapter title is one that's called "Fuck Desire." And the reason
it's a really good chapter. Yeah, let's talk about it.
But people get stuck on, I don't have desire for sex. They get stuck there, and then they have no sex life, right? And so my argument is, number one, if you're having mushy broccoli for dinner, nothing's going to make you desire it. So you need to care about the sex you're having more than the desire for it. And then number two is, so much of desire for some people, a lot of people, is in the doing and in the after. right? Like how many people are like, oh my God, that was so good. We should do that more. I forgot how good that was, right? Their
like,
sexual desire came after sex.
Yeah, exactly.
Right? And we don't get taught that. We like women are like, hard stop. It's the end of a busy day and I'm exhausted and I don't want sex right now. So maybe I never want sex. And it's like, no, you're just exhausted after a busy day full of not sexual contexts. And we're not light switches, you know? And it's like, well, how do you learn? You learn via watching Hollywood movies or your first boyfriend, something porn more and more and more. But like you're learning from bad resources. And then you think you're broken. And like this amazing, research done by Peggy Kleinplatz, who's like, she basically was like, who has good sex? And these people were like, I do. And she's like, can I talk to you? Like in her top 10 of people who have amazing sex lives, sexual desire is not in the top 10. It's literally not an essential ingredient. It's like communication, trial and error, vulnerability, commitment to the craft, right? Like you gotta show up.
Practice.
Yeah, you gotta show up. Don't rush. And so many people are like, I just don't have time. And I'm like, what amazing dinner do you wish went faster? What great movie do you wish was over sooner? Like this is literally pleasure, and we're like, I don't have time for pleasure. And you're like, maybe that's a wake-up call to your week or your life. Right?
I can't wait for you to teach this class. I just can't wait, because you must also, have ways you talk to patients about this. And we need to teach the docs how you're going to tell someone this, in whatever amount of time they have. But having a resource like your book to go along with it is so crucial. But I love these conversations. Yeah, the best part about sex is thinking about it afterwards.
Right? Like it's so good. Right. After it's done, it's so good.
It's like, it's like that. No, yeah, you don't.
Right? And I love like how you talk about when you're doing sex, you're like, this is what I want to be doing more of right now. This is it. You're like, yeah, but you got to be doing it to be in the enjoyment of it, right? You can't be like, dude, and my other thing I like to say is like, dude, we have so many distractions from sex now. Like, think back 150 years ago. What was the freaking best thing of the week?
You didn't even have light.
Yeah.
You're like, I need you to just be warm.
Yeah. Sex was seriously, nothing competed with sex. And now we're like, dude, I got Haagen-Dazs mint chip, a super comfy couch.
I got this square thing.
Yes, Netflix and this phone.
Yeah.
Dopamine, right? So sex is actually expensive dopamine compared to how cheap our dopamine is now.
That is brilliant. That is so true. It's so great.
I think about this all the time.
I think about this all the time. You're right. You're like, where do I want to put my dopamine? I mean, I could get up or make sure my legs are shaved, or I could just roll over and
connect with this other person.
I just do this
How are they
movement
feeling?
with my thumb. It's easy.
Very cheap. Zero calorie expenditure.
Exactly. This is so true. And I love how you talk about the mirage of spontaneous desire, right? That all of a sudden you're just going to break out in spontaneous desire, and that is the only way to have good sex.
Yeah. Yeah, I mean, Rosemary Basson, who is one of the researchers who came up with the responsive desire model, which is not just women, it's people. But, her argument is most sexual desire is responsive, right? Just some people in our society are more allowed to desire, and their sexual triggers, things that make them think of sex, they're just more apparent for them in the world. We've got boobs selling fucking hamburgers in this country, right? And so it's thinking of desire as you're surrounded by a context that is sexually stimulating to you. There might be less of your context in the world than somebody else's context, because we use their context to sell Mercedes. Right. That and also truly a testosterone of 800 does affect the brain differently than a testosterone of 20. Let's be honest. Right. So the wind can blow and you can get an erection when you're 18.
Yeah, exactly. I always kind of had this theory, and it's never been, I don't know if I've ever really talked about it before, but I think that there's a peak in women's sexual response sometimes in their, I don't know, sort of maybe before or early perimenopause. And the reason I think I see this is because their brain is like telling their ovaries are like, come on, give me some estrogen, give me some estrogen. And I think there's a little bit of I've seen a lot of patients that have this like great robust libido then right before perimenopause. And I'm like, I
Yep.
think that's also your body trying to just squeeze out whatever you've got left. And
Yep.
then you can see the physiologic impacts of testosterone, right? It's not
Yeah.
all
Well, I mean, I
testosterone,
think estrogen too, there's plenty of data that estrogen is a
but
desire
estrogen.
hormone. It's like
Exactly.
we've just stereotyped, we've given that to testosterone, and that testosterone can't possibly affect
Do
anything else
anything
in your
else.
body,
Right.
which is very, very boiled down. Like, does people who are saying you can only use testosterone for desire, like, do they understand physiology? Like,
I talk to my
it makes
patients
no sense.
all the time. If you're going to prescribe a blood pressure medication, it's like very obvious. It's like going to cause vasodilation, and then the vessels are going to go up, dilate, and then blood pressure is going to go down. Hormones change your DNA. They go into the
Yep.
cell and they actually change your DNA, what you're expressing,
And your mitochondria.
Exactly. And your mitochondria. So they change you at the cellular level, which is why it's so much harder, which is why there is more of an art than a science, because some people, estrogen actually improves their libido. That's why sometimes I stack and I do that first. Sometimes it is the testosterone. Sometimes people don't like progesterone. Sometimes they do. Sometimes people like the patch versus the gel, even though it's the same medication. Why? It just may be affecting the cellular level different. And we're just not smart enough to understand why. The best we can do is watch and follow. But absolutely, it's ridiculous that we give hormone specific jobs. It's helpful when we're trying to teach, but at the same time, it's also it's fascinating because in clinical practice it can be so different.
Totally. Yeah. And so, I mean, the big question is, how do you teach a doctor, a nurse practitioner? How do you teach a clinician to help somebody with their sex life in 10 minutes? Right. Like, now that's what I've been doing. I've been in the insurance-based medical practice for my whole career. I'm getting out of it now.
You're about to leave.
I'm about to leave it because
Welcome to the other side.
I truly understand that the doctor-patient relationship's so broken now, and the 10-minute visit, I think, is 80% to blame.
Wow, 10 minutes.
Right? No, it's insane. And so to me, I'm like, I joke, I'm like, I worked very hard to work very minimal in the clinic. I'm like, read my book, listen to my podcast. It's all written down. And plus they can consume it in the safety of their own home with their own thoughts. They're not under the pressure of being in a doctor's office and feeling rushed. Is like, go get the education, then come back and let's adjust. And I especially do that for, I mean, a lot, probably your people too. Like, people are educated by the time they get to me now because they know what I've provided out there for free. Right.
Yeah.
So you can be like,
really...
okay, they've read the book, they've read the podcast, they want the hormones, they want the, non-hormonal meds for desire. Like, they're there already.
Oh yeah.
Like, it's that barrier of like,
yeah, they're starving. They're hungry for it. They're excited. There's one other thing we need to talk about is the next generation. But, I've been doing this for 10 years. So I always like to ask patients, this is a little Heather thing that I always do, is I always say, do you have any guesses as to what might help? And that's, as a clinician, that's helping me meet them where they are. And, years ago it was like, well, I don't know, they're just so confused. And now they're like, the 0.05 twice weekly estradiol patch, plus 100 milligrams of prometrium. I'd either like to try Testim gel, and if that doesn't work, maybe Addy. And then of course, like vaginal estrogen, and can I also use it on my face? It's amazing. Yeah. Like, they already know, really.
And how much more fun is that for you?
Oh, it's so much fun. I mean, I can't help but to not have
the we don't have to not have the estrogen doesn't cause cancer conversation, because they already understand that.
They already understand it. Exactly. And, it's so much fun. And then, you just get to meet amazing women who are doing amazing things with this information, because once they learn it, they're like, this is fucked. I'm like, I know. And then, they go off and tell all their friends. And I always say, it's great that there's so many social media docs, but we really need you telling your friends. That has even a bigger impact because the girlfriend effect is so strong. And now let's talk about the current 30-year-olds, because the current 30-year-olds ain't going to suffer through perimenopause or menopause.
Preach.
They just are not. And it's going to be so interesting to see how that generation is going to go through menopause. And I'm kind of talking about the women who are mostly like premenopausal, right? Not even peri or in menopause. And I'm just interested to see how it's going to go, because I really wonder if we're going to have 10, 20, 30% of women on HRT if we just wait long enough.
You know what I think? I mean, you were talking about this earlier in this episode. You were like 5 years from now, blah, blah, blah. And I'm like, I was thinking yesterday, 50 years from now, because I was texting somebody and about like, what, like the hormone experts are going through it right now on people kind of backlashing and them being like, we're saying everybody should be on hormones. And we're like, we've never said everybody, but we have said a lot of people can benefit from this.
Great
Please talk to your doctor. Right?
This is the best episode ever. This is just airing our grievances.
Right? I know. So, but I'm like, okay, what's 50 years from now? When we are freaking old and we're sipping our coffee on the porch, what is, and we're going to say we were at the beginning of this, Heather. We're at the beginning of change, because I truly believe we are changing how we're aging. And that's starting with the boomers. The oldest Gen X is turning 60 next year. Born in 1965, 2025, 60 years old. So they took care of their boomer parents. They saw mom fall. They saw their parents have dementia. They saw heart
urinary tract infections.
They saw frailty. They're not going down like that. This is the first generation that says, I see what air quotes aging is, because we've fixed the blunt trauma, we've fixed the infectious disease, we've fixed death from heart attack. You are now going to be frail if you don't intervene, right? So Gen X is changing aging. Longevity includes hormones. I think 50 years from now, pending craziness, 50 years from now, hormones are going to be the default. Certainly by the educated. I think by the educated, they're going to be the default within 10 years at this point.
I was going to say, I don't know if it's going to be 50 years, but I think certainly yes. I totally agree with you. And it's so funny. No one comes to me and says, I don't want to age. Of course not. Like, people do understand, but they want to age well. They want to have good quality of life. I think that the discourse sometimes is, some of us doctors are prescribing hormone therapy willy-nilly for all these. No, not at all. Like, this is, again, a very misogynistic view of lay women understanding what is happening to them. It's not rocket science. It is not rocket science that as we lose hormones, we do see signs, air quote, aging, whatever that might be. And, I think if we have evolved, our ovaries should have lasted till they're 70. 75 at this point, at least 70, but that didn't happen. And so I just think the whole thing is very interesting. My sister, who's a few years younger than me, so she's in her late 30s, she calls me and she's like, Heather, I think I'm in perimenopause. I haven't had a period. I'm like, no, you're pregnant. No, I'm not. She's like, nope, not a chance. I run her labs. And her FSH was high and her estrogen was low, and she skipped 3 months without a period. So she's like, give me that patch that like Courtney, my sister. I got to get her on my show because this is a really, really funny story. You
should have your sister on your show.
She's so funny. I know we keep saying
my brother's coming on my show like next month.
Oh, I didn't even know you had a brother. I have two sisters. Yeah. Do you have a brother? Do you have any other siblings?
Two brothers. Two brothers.
That's fascinating. Okay, I have two sisters. And so I'm like, well, do you want to know anything? She's like, no, don't you? Isn't going to help me sleep and stop my flashes? And I was like, yes. She's like, great. Put it into CVS now.
She's been listening to you. It's so awesome.
I
think perimenopause is the next big movement. But to change the medical paradigm from treatment to prevention, that's a big paradigm shift.
Itself
that's what we're asking medicine to do. And it's big.
God, Kelly,
it's very big.
I know.
But like, dude, your peak bone loss is in the 2 years before your periods end. You don't know. That's a prospective date. You don't know when that's going to be, right? But it's like
the reactiveness of the medical system is failing us all. Like, everyone is over it now. And, a lot of things have to change. A lot of things have to change. When I think about medical education, because I guess that's kind of my little niche now. Like we've all developed our little Venn diagrams, right?
I know, I love us.
I'm sort of in
Yes,
the middle
what's your
of
Venn
like,
diagram, Dr. Hirsch?
I don't know. I think it's like, it's kind of perimenopause and menopause, but I feel like mine's probably education. Sometimes people
You
kind
sit
of
in
come
the
to
Venn
me.
diagram. I'm going to tell you what your Venn diagram. You can disagree. You sit in the middle of the Venn diagram between midlife health and medical education.
Oh, okay, great. Perfect. No, I don't disagree. I love that. I was like, don't say mental health because I sometimes get, and I think it's a huge part of it, but I am no expert in terms of, bona fide being a, psychiatrist, but I do talk a lot about mental health. So I was like, oh no, don't say that. Don't pigeonhole me. Like, I don't know that I can do
I
it.
wouldn't do that. You know what I want? You know what I want to see? Another course from you, if you can. You're brilliant. You're probably already working on this. I want somebody. And if you don't have anybody, I promise you in 2025, I will pull all the data and I will do this. But I want a course on hormone therapy for women greater than 10 years postmenopause.
Oh,
Go through all of the studies.
Yeah.
Because the prevailing wisdom is that estradiol transdermal ain't unsafe for these women.
Of course, I don't think so. I mean, here's what I would do. So I was like, ooh, test me. I've got so many ideas, PMDD, PCOS, etc. But like, so I would say I start what I would, so I don't have what I would probably want to do is look at, again, this is a study that needs to be done. Can you safely give women who've been outside of the 10-year window transdermal estradiol? And I routinely do, especially if they're overall healthy.
They're all they're bone studies.
Yeah.
But the secondary endpoints are safety.
Yeah, exactly. So we could look at we can look through all of those. Papers. So it's again, that idea stems from Premarin that after 10 years, and actually if you even look at the WHI, it was really after 20 years. The women who are between 10 and 20 years from their LMP, there was a null impact on cardiovascular disease, meaning this is oral. So this is oral Premarin. This is not, as Kelly was just saying, looking at transdermal. So if we're looking at the WHI, they started women who are 10 years out to 20 years out and saw a null impact on cardiovascular events. If we just use cardiovascular, right, which was like the biggest fear, we're going to give you a blood clot and you're going to die. And so they actually saw no effect. So that means that you didn't get the same benefits as you did in reducing the risk of cardiovascular disease if you started within the 10 years. But where the risk sort of outweighed the benefits was really when you were 70 or 20 years postmenopausal, or 20 years since your LMP. That's actually when, so like, there's probably a ton of data how safe, and this is oral, transdermal estrogen is if you're 12, 13, 14, 15, 16 years out of, menopause. And I routinely do this for my patients, especially if they're well counseled, if their other cardiometabolic diseases are, either non-existent or in good control. And knock on wood, all of my patients are doing fantastic. This paternalistic view, I've been doing hormone therapy for the last 10 years. I've had one clot in 10 years. And
that's a very safe medication. Show me a medication with less risk than that.
What exactly? Now, I've had women develop breast cancer for sure, but that, again, this is like I don't want to put that in there because women are going to develop breast cancer whether they're taking hormone therapy or not. Common. Right? Breast cancer is common, and all of my patients, nobody was. In fact, most of them wanted to continue their HRT through their breast cancer treatment because, again, women should be allowed to make their own medical decisions. This patriarchal view of like, oh, sweetie, you can't have that anymore just because we kind of said so because there's estrogen receptors in your breast tissue, even though there's estrogen receptors everywhere. It's just illogical. But again, that emotional response to estrogen and testosterone is so real. We've been talking about it for the last hour.
Totally.
So,
can I ask what I want to ask one question that I'm hoping we can fit in before the end of the podcast. Perimenopause or early menopause, woman comes in, she gets her labs checked. She has new high cholesterol. Wasn't high before. First time high. This is off label. We can put all of our little asterisks on this conversation. I want your opinion. And it's more of a, is it okay question? Not like, what would you do? Is it reasonable to start woman on hormones, optimize it, and recheck her cholesterol?
Yes.
Thank you.
Of course. Now use transdermal because we want to avoid first pass liver metabolism.
Yep.
Use transdermal, of course, if she comes in with elevated lipids. This is a question I get all the time. These are real questions. These are real clinical questions. Why can't we do research on this? However, statins, we could debate all day about statins. I definitely, wouldn't want to. I'd probably get creamed. But statins do increase there's data to show that increases the risk of diabetes. And so there doesn't need to be necessarily a rush to go on a statin, especially because most doctors seemingly don't calculate ASCVD risk scores, where you look at the fact that if she's not a smoker, if she's not a diabetic, if she's younger, if she's got good blood pressure, like you don't need to rush to put on a statin. And I would say of all the women who wait a good 3-6 months to then repeat their cholesterol, sometimes you do see it come down, not always, but sometimes. And so I don't know exactly the pathophysiology of that, but abso-freaking-lutely. And not all women want to jump on a statin, especially if you're just going to start hormone therapy. Do one thing at a time. So yes, and yes.
Thank you. That was my big, I think this, all the data to me sounds, for all the reasons. I love it. Do you have any last questions for me before we wrap it up?
Yeah. Tell me what you find when you do, prescription, not pellets. I know you'll do testosterone injections at times when patients aren't responding well to transdermal. You're going to talk about this in your course, and I can't wait because I always just get a little tense because I like being able to control HRT more, and the injections always a little worry me because they last a little bit longer. But who's a good candidate if the transdermal testosterone is not seemingly working well, and they want to go to injections, not pellets? When do you use them and how do you do it?
Yeah, so I have them compounded just because I think it's an easier dose. The male products, so there's injectable male products available. They're intermittently back ordered. They might give them the different dose. They're single use only. It adds all this complexity to it, let alone it's a 200 milligram vial. So it's freaking huge because in a woman, you want like 1/10 the dose, right? So you're going to go a lot lower. So I usually compound it. But before a woman says that testosterone transdermal doesn't work, I'm checking her levels. Did she actually absorb it? Is it, these are American levels for anybody who's international, but like maybe she got to 50 on it and she actually is going to respond really nice if I get her to like 100, 110. I think and this is Kelly Casperson's personal opinion of doing this for years, the side effects are pretty minimal under 150. And there are some women who do respond, and the data supports this, a little bit above what air quote physiologic is. And we can argue that we don't know what physiologic is because there's been like 3 studies and they're all different. But so the people who respond do a little higher physiologic. I don't mean pellet level physiologic. I just mean.
We don't need you 350.
No, you do 350. I think 150, if you made me give you a cutoff for where I really start seeing androgenic side effects, it's above 150. So my point is, where is she getting on the transdermals? Do I want to just try to push that a little bit more? I love the steady state of it. I love especially if we compound it, 1 pump a day. In the documentary coming out, the M Factor, there's actually me with a packet of testosterone gel showing that it's like very hard to microdose a packet. Like nobody would say this is a reasonable way to dose a medication.
No, exactly. We always have, exactly. You got to go to Amazon. You got to get some glass droppers. It's a thing.
It's a thing. But so, I mean, most women don't. I think the only women who really like injectables are the ones who kind of like think they're cool because that's what the like.
Well, yeah,
cool people like there's a coolness factor kind of in that culture
I'm
about
so
injectables. like this is what all the really elite people are doing. Whatever. Most people don't want to do an injection once a week, but I could argue it either way. I just think transdermal is very safe. It's very hard to get super physiologic, and most women And the other thing is like, so I pump your testosterone up to 80, pick a number, and you still have low desire. Great. I can pump it up a little bit more, or we can say the things you're wanting fixed by testosterone are not being fixed by testosterone in you. Right. That's also very possible.
Start planning some sex.
We gotta look at
Oh,
other things.
it was so much fun catching up. Like, I'm so, I'm manifesting that we co-host a show on Hulu. That's what I'm manifesting. That's what I'm going to manifest. I just think,
we should have a show.
I don't know why.
Things that get manifested on this podcast freaking happen. It's happened multiple times, not just once. So this podcast is a manifestation machine.
Great. So that's what I'm manifesting.
Just saying. I love it.
Just saying. And thank you for, doing this co-podcast with me. I love hanging out with you. You're just such a positive, wonderful light. I'm so thankful to call you a friend and colleague of mine. And I just love all the things that you're doing that we get to do together. I mean, thank you, girl.
I'll always keep coming back to Heather Hirsch.
Oh,
plus both of our names are alliterative and it's really cute.
Yeah.
That'll be good for the Hulu documentary.
Oh, it will totally. Heather Hirsch, Kelly Casperson, Casey. Yeah. Everyone's sick of hearing my name because everywhere. But have a great afternoon and thanks, Kelly.
Thank you, my love.
Bye.